Thank you very much for your introduction and thank you for invitation. And may I ask you, how many of you are, or better, are not geriatricians here? Okay. So let me start with 2 or 3 slides on a comprehensive geriatric assessment. And that is the cornerstone of geriatric medicine. And so we start with the original definition by Lawrence Rubinstein, who published the first randomized clinical trial on the comprehensive geriatric assessment in New England Journal of Medicine in 1984. The definition by Rubinstein of the comprehensive geriatric assessment is a multidimensional, interdisciplinary diagnostic process to determine the medical, psychological, functional capabilities of a frail elderly person in order to develop a coordinated and integrated plan for treatment and long-term follow-up. Why? What is the clinical base of the comprehensive geriatric assessment? The heterogeneity of the aging population. We have many ways to have 100 years. There are many ritas and different ways to be a centenarian. Why? This is due to a different genetics, biology, the diseases, the disability, the cognitive status, and the psychosocial, the income, the family, the cohabitation status, and we need to measure all these things and to integrate all this information in a unique index, in a unique parameters. This is the comprehensive geriatric assessment or multidimensional assessment. What it means from a clinical point of view, that we are not satisfied with a classical medical evaluation. We need the study of functional, cognitive, and mood with appropriate instruments validate in the aging people. And we need to calculate the biological risk in terms of nutrition and mobility. And we need also a social evaluation. Why? Why? Because at the end, in this manner, we have the opportunity to have the clinical profile of subjects, the pathological risk, and the residual skills in order to develop the individual care plan. It works, the comprehensive geriatric assessment. We have 3 decades of trials, and you can see here a selection, a very recent selection of several review and meta-analysis performed in different healthcare settings, hospital, post-hospital discharge, community dwelling population, and all these meta-analyses confirm that we have a reduction in short-term mortality, in institutionalization, in hospital readmission, and so on. And we have also a lot of solid evidence-based information that the comprehensive geriatric assessment approach is significantly useful in terms of reduction of mortality in hospital and long-term mortality, or post-operative complication, on also reduction in combined outcomes in terms of mortality and functional disorders in different clinical settings: oncology, orthogeriatrics, surgicals, dementia, and so on. So the conclusions are that programs of comprehensive geriatric assessment at home or in the hospital showed to be consistently beneficial for several health outcomes and in specific clinical conditions, especially in older patients. And frailty is right, Professor Franceschi, when he said before that geriatricians should prescribe physical activity and nutrition. Why? Because they are demonstrated to prevent and reduce frailty. Frailty is an increased risk of negative health status outcome: fall, delirium, institutionalization, hospitalization, and death at the end. Comprehensive geriatric assessment is the internationally established method to assess elderly people in clinical practice, and is defined the gold standard to detect, to identify frailty, and to measure frailty, and should be used more widely. Yes, it's true. It should be used more widely. Even in infectious disease, yes. Everybody knows that there are risk factors for infection disease in the elderly. And among these risk factors, there are also, for example, mobility limitation. And other examples, poor functional status may be a risk factor for severe Clostridium difficile infection, and so on. We have a lot of examples. Even in this very recent review in JAMA on urinary tract infection, again, we have local factors, including the urogynecologic surgery, retention, urinary retention, and incontinence, but also functional disability in old age. And the geriatric syndromes are included as an essential spectrum of clinical presentation in older patients, almost older patients with HIV infection. And so the conclusion of this author is that geriatric syndromes are very common in older infected adults, and clinical care should consider incorporation of geriatric principles. Incorporate geriatric principle, it means incorporate the comprehensive geriatric assessment. After 3 decades of CZA, we have new challenges. From a methodological point of view, we are project with domotic and robotic evaluation for the comprehensive geriatric assessment. New challenge in terms of evaluation. We are able to compare the different methods in terms of discrimination, accuracy, calibration, generalizability, feasibility, and clinimetric properties. And we have the new challenge in clinical use of comprehensive geriatric assessment, that it means to obtain a prognostic information in order to have and help in clinical decision making. What it means to have a prognostic tool derived from a comprehensive geriatric assessment, to combine the different 8 domains of a standard comprehensive assessment, activity, basal and instrumental activities of daily living, cognitive, nutrition, mobility, comorbidity, polypharmacy, cohabitation status, and organize all these domains in one index cumulative that we call multidimensional prognostic index, that is number continuous from 0, lowest risk, and 1, highest risk. From a clinical practice with appropriate cutoff, it has been possible to divide this continuous value in 3 categories: low, moderate, and severe risk, in this case of short-term, 1 month, and long-term, 1 year of mortality. We use this index during the last 10 years in many clinical situations: acute gastrointestinal bleeding, pneumonia, transient ischemic attack, or chronic dementia, liver cirrhosis, chronic kidney disease, heart failure. And in particular, in infection disease, in pneumonia, this is an experience in hospitalized patients with a mean age of almost 79 years. The index was excellent in predicting mortality in a short term and long term. And it is very interesting because the accuracy in terms of sensitivity and specificity is significantly higher of the MPI compared to the pneumonia severity index, for example. And this is a result that is an expected result in this older population. The conclusion are that this index was a sensitive measure of the multidimensional risk assessment that may be useful in identifying elderly patients with pneumonia, different risk of mortality. We confirmed very recently this data in a very small group of subjects and compared the accuracy in terms of predicting mortality with procalcitonin. And it is interesting because combining the 2 parameters, multidimensional approach and procalcitonin, at baseline, is it possible to significantly increase the prediction rate, but at discharge of patients when the clinical conditions are stable, MPI was excellent, 84% of accuracy, and the inclusion of procalcitonin did not significantly modify the accuracy of the MPI. At this point, I would like to conclude on MPI, showing this data on, by our colleagues from the Netherlands. They compare the validity, reliability, and feasibility of tools to identify frail older patients in hospital care, and they establish a QUADAS system that is a quality evaluation of the predictive tools with a range of quality from 0 to 14, and MPI and modify MPI that is that include the mini nutritional assessment short form instead of the full full range mini nutritional assessment. MPI and modify MPI obtain the highest value, 14. More recently, this review article on frailty measure in research and clinical practice, this review from Australia, United Kingdom, and again from the Netherlands, they identify a sort of very well-known frailty instrument, and at the end, only 3 are of this instrument based on a comprehensive geriatric assessment. One, the frailty index described, validated, and developed and validated by Rockwood in Canada, that is based on more than 13 items and require more than half an hour. The Morley Frail Index that requires less than 10 minutes and is a screening tool, and the only one tools developed and validated in Europe and in Italy is the MPI. 15 minutes, 8 domain. At the end, and with this background, we start with a large project that we call MPIH, and the UGMS had the role on the leader of the dissemination, and with most than 20 partners, we decided to evaluate the role of MPI to improve the cost effectiveness of intervention in multimorbid, frail, older people. And I would like to show as a design just 2 things about the work package 5, using the MPI to evaluate the drug treatments in older with multimorbidity and polypharmacy. And we start with a series of gray areas in clinical treatments of the elderly people. Statin use, anticoagulants use, or the use of drugs for dementia are very useful in older people or not. We start with statin. Our friend Timo wrote on JAMA that we don't have randomized clinical trial of statins in older people older than 80 years. So it's difficult to decide what to do over 80 years. And over 80 years, people are heterogeneous, with varying life expectancy, may have or not frailty, or comorbid condition, and may take multiple medication, and the decision to treat is difficult. It's not evidence-based. So we select 2 clinical situations in which randomized clinical trial support the use of statin in secondary prevention. The first is diabetes. From a large database from this region, Veneto region, we select 1,700 patients with diabetes who underwent a comprehensive geriatric assessment to establish accessibility to home care service or a nursing home admission. Of course, the mortality after 3 years of follow-up are significantly higher in MPI 2 and in MPI 3 compared to MPI 1 class, 12, 24, 35%. The statin prescription by physician is on reverse, higher in the lowest risk group, lower in the highest risk group. So at this point, it's clear that the functional, clinical, and also in terms of polypharmacy, condition between patients who are not treated compared to treated with statins are significantly different. And so we need to use a post-matching with analysis in order to compare and have, with a propensity score analysis, to two populations who are completely similar in terms of multidimensional evaluation, comorbidity, cancer, dementia, stroke, and also number of medication, first, second, and third. So at this point, we have two populations that are completely similar and are different only for being treated or not treated with statin. With this analysis, we have the opportunity to evaluate the association between statin use and the reduced mortality. And indeed, in the MPI-1, low risk, the statin use reduced 21% of mortality. In group 2, 33%, and in the MPI-3 groups, almost 70%. Dividing patients also according to the age, more than 65, more than 75, more than 85 years. Again, we observe a significant association between statin use and reduced mortality. The conclusion were that statin treatment was significantly associated with reduced 3-year mortality independently of age and independently of multidimensional impairment in this population with diabetes. By the way, just 2 slides for giving you the information that older people with coronary artery disease, almost 2,600 people, are completely similar, the results, in terms of mortality, in terms of statin prescription, and in terms of results. And so the conclusion were that statin treatment was significantly associated with reduced 3-year mortality independently of age and multidimensional impairment, although the frailest were less likely to be treated with statins. This is a scheme of use of the MPI in evaluating the treatment. For example, in dementia, we evaluate 3 years of follow-up in 6,800 people, and the results are a little bit different. Because with the propensity score analysis, we found that the significant association between treatment with anticholinesterase and memantine reduce mortality in the MPI low risk and moderate risk, but not in patients with high risk. And this is confirmed with another kind of analysis, with the conclusion that the treatment with anti-dementia drugs was significantly associated with lower mortality only in subjects with low or moderate mortality risk as assessed by the MPI. This is very interesting because the MPI grade is associated also with a sort of metabolic signature. That it means that in the three groups of risk, 1, 2, and 3, there are a significant, completely different, significant trend in terms of inflammation, and we know very well from the many studies of the Professor Franceschi, and we confirm, of course. Nutrition, metabolism, hormonal, and so The sound is that this increased risk from a multidimensional point of view corresponds to a metabolic signature. Of course, all analysis has been adjusted for comorbidity and gender, and all drugs stating anti-inflammatory drugs, cortisone hormones, that may influence the parameters. At this point, my feeling is that we are ready to use the MPI in the infection disease and in vaccination as a target. And indeed, during the last Congress in Lisbon, we have a meeting, a formal meeting with a special interest group on infection disease and comprehensive geriatric assessment to evaluate the possibility to start with this multi-center European survey, with the aim to evaluate in a real-world population of older hospitalized patients with different mortality risk, the prevalence of infection disease, including the vaccine-preventable infection disease. My feeling is that this is absolutely an innovative perspective, because we need, as clinicians, to consider the prognostic information that it means survival life, obtained through well-validated, accurate, and calibrated prognostic index. This is essential. This is a point, the start point, to identify those patients who may benefit from intervention, given with the aim of increasing survival, for example, vaccination. Thank you. This is our group in Genova. And for entry more in detail on the MPI and the MPI age results, the next week, oh no, the 2 weeks, the June 7, we will be here for the final event on the MPI age project here in San Servolo. And the day before, the 8th of June, we will be on the Palazzo Ducale in Genova, on the other side of the Italy Mar, always in front of the sea. Thank you. Thank you for your attention.
Thank you very much, Professor Pilotto, for this very interesting overview and I think introduction of the auditorium to this important instrument in geriatric medicine and multimorbidity. There is a first question here.
Well, thanks for this presentation, because I like a lot, because go on the direction of using tools to characterize the health of the people, to target intervention, including vaccination. I would also stress that there are a lot of data in the literature suggesting overall that frailty or many other diseases of the elderly can be conceptualized altogether as accelerated aging. So frailty and many other diseases, including something that can occur in young people, because you can measure the biological age also of young people. So we can arrive to, I think, a vision where a multidimensional assessment clinically, which is very powerful, together with the tools that I tried to illustrate this morning, probably can combine and arrive to something which is even more powerful for assessing the people for identifying those who will benefit more of any kind of intervention, including vaccination?
I completely agree with you, of course, but we are ready. My opinion is that we are ready as clinicians with the multidimensional instrument, and you are ready with the biological age, bioage knowledge to combine and to improve have information more detailed. Thank you. Thank you for your comment.
There's one more question possible.
Yeah, thank you, Alberto, for your nice presentation and all the work you did. You said that MPI may change decision making. It means that, and for people who are not used about geriatric assessment, it means that MPI is very useful to have a very fast view of who is the person here. But when you are, and it's my question, when you are in the ward and you have a pneumonia, you did it in pneumonia, but perhaps we need more, in bacteremia or what else, infectious disease, acute, you don't have, and perhaps we have to add to the MPI another score, for example, PSI or others, measuring the severity of the disease. You have the host factor, but you have not what happened just now. I don't know if you follow me, but it's the question of who is. I think MPI is very good, but we need to add to this which is the stressor. Because if you have a cancer, it's not the same that you have an infectious disease. It's not like an infarctus. And all these things are important to make a good prognosis. And finally, to have the most ethical decision making.
Thank you, Gaetano. It's not easy to follow you because you run very fast, usually. And, but you are right. And we need to return some steps. And the multidimensional approach may help you in the process of clinical decision making. Now we don't have nothing. Timo demonstrate we don't have information over 80 years old for statins. And most probably in a lot of treatments, and including physical activities, including nutrition, including, I don't know exactly because I am not an expert, including vaccination, maybe. And this is an example on how a scientific society may give some information, some new data in order to have the possibility to a more evidence-based clinical decision making. So we have a lot of work to do. I agree with you. Thank you, Gaetano.